Hi, this is David. I did my practicum at University of Kentucky with their rapid response team. My learning objectives I wanted to achieve by the end of the practicum were to be able to identify interventions that the rapid response team utilizes when activated, identify patient care scenarios when rapid should or should not be activated because they're oftentimes activated when they should not be, such as calling and asking them to transport a patient to CT because you're too busy, and the use of this knowledge to develop an education piece for bedside nursing on an appropriate utilization of the team and to help prevent some calls that aren't what the team is designed for. I was able to meet my objectives by shadowing nurses that work on the team, participating in patient events, interventions, and learning about the team's processes, procedures, and roadblocks that they experience. The team itself is made up of two nurses. They work 8 a.m. to 8 p.m. They're located close to the main entrance of Pavilion A, and basically they function together kind of like a little mini ambulance team. However, if there are multiple calls going on at once, they will split up and each one go to a patient. When it comes to best practices, UK, just by virtue of having a rapid response team, is following best practices. Many states and don't require rapid response teams, and many hospitals do not have them. So it's very beneficial to our patients that we do. Comparing what I experienced with the literature, the class textbook touches on rapid response several times and states the importance of interdisciplinary teamwork and that being at the center of success. I saw many cases of disciplinary teamwork when we were taking care of our patients, of getting everybody together, talking to the nurses, working with the techs, working with transport to get the patients moved, working with the house. They call it a HOA here, but basically the house supervisor that works on kind of where everybody's going and everything. In addition to improving outcomes for at-risk patients, the rapid response team also serves a valuable triage function. They expedite the movement of patients from different care areas, typically from a lower care to a higher care, such as an ICU, that frees up space for them to bring somebody up from the ER or just have more time to focus on the patients that they were currently assigned. Um, yes, appropriate triage can also prevent diminished capacity in your specialty areas because we only have so many ICU beds. We only can run so many patients in the cath lab at a time. Um, so by preventing them from going somewhere they don't need to be, it saves on resources. At University of Kentucky, when there's somebody that they call a STEMI alert on, they go straight via the ambulance to the cath lab, and rapid response responds to the cath lab to help get the patient together and ready to go into the cath lab, and also to triage them, such as the patient that we had when I went to the cath lab, who was actually a GI bleed patient who was having chest pain from previous surgery that he'd had, but it wasn't actually cardiac pain. So by getting him triaged, we were able to move him down to the ER and out of the cath lab. Research on the rapid response team's effectiveness has shown that early and appropriate activation of the team is key to positive patient outcomes. Conversely, delayed activation is associated with higher rates of mortality, longer stays, higher ICU admissions, and a higher risk of cardiac arrest in patients showing signs of clinical deterioration. Research has also found that more experienced nurses are more likely to utilize rapid response, and that nurses may not use rapid response properly because they haven't received proper training. This is what helped me come up with my project of a handout that I designed or came up with. Basically, I took the very kind of dense, really kind of convoluted policy that UK has on rapid response and tried to sum it up into something simple that can be put like in the bathroom reading that they have at UK, where people can glance over it and get ideas of when they need to call. So obviously it starts with, are they showing signs of decline? If they're not, then you just keep doing what you've been doing. And if they are, then you call rapid response in the primary team. What are some of the early signs of clinical decline? It can be as easy as a gut feeling. I found from all my years working on the ambulance that sometimes there's just nothing you can see, but you just know something's wrong. The key example of that, I had a patient that was in a pretty minor fender bender, but was pregnant and complaining of abdominal pain. What we used to call an EMS insurance pains is what it appeared to be on first glance, but for some reason I just didn't feel right with it. So I called, talked to the ER doctor who knew me. He had ultrasound and everything ready when we got there. And within about 5 minutes of me rolling in the door with her, they found out she had a placental abruption and rushed her up to the OB unit. Other signs, heart rate less than 50 or greater than 120, acute changes in blood pressure, systolic less than 90, respirations less than 8 or greater than 24, change in respiratory effort, mental status, oxygenation, acute hemorrhaging that, you don't know where it's coming from. If they've got a cut, obviously, then, and that's what they're in there for, that's different. New or infrequent or intractable seizures, temperature less than 95 or greater than 101.5 with other vital sign changes, and obviously not somebody who's been that way for a while. An acute onset of pain and other things as you see fit. Another one is oliguria, less than 30 cc's an hour for 2 hours, means your body's shunting blood away from the kidneys, which is the first place it takes blood away from, showing that you have poor perfusion to your other organs as well. So when do you need to call? Well, here's a couple things to think about other than what I just told you. At our hospital, SCM, which is our paperwork, like our electronic medical record, automatically sends alerts to the rapid response team. So you need to educate the techs and also the nurses too, that when they're doing vitals, they need to make sure things are accurate. Is the pulse ox on the same finger as the side they're doing the blood pressure on? They often do that because they're on that side of the bed, but it can record a low number. Is your blood pressure cuff placed properly? If the heart rate looks out of whack or abnormal, did you auscultate it to see if it's actually true or not? Many of the automated alerts that the nurses got were just from simple things like that. So anytime the vitals come up, basically blinking or dinging on the machines that we have, the techs need to know they need to recheck it and then come find the nurse, because those are going to generally automatically contact rapid response. And then if they're busy with somebody that's truly sick, then you're taking their time and resources away from that patient that is deteriorating. But at the same time, you need to pay attention to your patient. If the patient's agonal, don't call rapid response, start bagging them and call a code. Code will automatically get you rapid response. You also don't have to page rapid for a stroke alert. They're automatically notified. If you call again, you just slow them down. They stop what they're doing, stop heading towards you to try to figure out what's going on, because for all they know, it's another patient in distress and they may have to split up. And also, if someone else on your unit already called for rapid and you're calling again, this actually happened on my unit while I was with rapid. One of their patients was going down and two different people called from two different numbers, and we had to stop what we were doing on our way there to call and find out basically that it was the same unit. So that definitely slows things down. Some observations when I view my practicum through the lens of the class material, the biggest things that stand out for me are strong and weak, both interprofessional teamwork, mostly strong though. I was able to follow the rapid response nurses and their work through a variety of patient situations in multiple departments throughout my hospital. For me personally, this gave me new insight into how my hospital functions outside of my work environment. I saw plenty of examples of interdisciplinary team members working together in the um, in the in the patient's care. However, I did also see a negative side of that. I had an oncology patient who was having brain swelling and brainstem herniation from the water she was being given IV to help her kidneys flush out the chemo. So she's having all the different neuro changes you would see all the way down to corticate posturing, and neurosurgery wouldn't take her because she wasn't a surgery patient. Neurology wouldn't take her because she was on chemo, and they said, quote, "I don't know how to handle that," um, which the hematologist just couldn't fathom. But those patients need to be where neuro nurses are. We ended up taking this lady to PACU, and PACU nurses have to know a lot about a lot of things, but somebody that's having obvious neuro signs needs to be on a neuro unit. So the only people that would accept them was the pulmonary team, and the pulmonary team didn't have beds, so they ended up in PACU. And I think that was a real disservice to the patient. Here's my references. If you have any questions, let me know. I enjoyed having class with you all, and I hope everybody gets through class well. Have a good night.